my first time in Saskatchewan, so thank you very much for inviting me. I don't have any financial or personal conflicts to disclose, only to say that I make this diagnosis quite a lot where I work in the emergency department, and so I have a great personal interest in treating kids with concussions. So what we thought we would cover today, we're going to just talk initially about what a concussion is and the most common causes in children, talking about how we recognize this injury with the signs and symptoms that children report. We're going to talk in a bit more detail about how concussions are treated in children, and this is an area where there's some change and some new research that's come out in the last few years. And we'll talk about protecting and preventing concussion. What are the things that have been shown to be effective for concussion prevention? And throughout the webinar, I'm going to give you some suggestions about good, reliable concussion resources that are available online. So I know, having spoken to Kara, that we have lots of different people on the webinar today, all of whom work with children in different domains. So whether it be education, injury prevention, healthcare, psychological support, all these different domains that we are touched by concussion, no matter where we work, if we work with kids. And I think that probably comes to the fact that if I asked you, if I could see you, I would ask you to put up your hands and tell me if you yourself have experienced a concussion, or if somebody in your family or in your close group of friends have experienced a concussion, or if you've ever helped or treated a child with concussion. And I bet all of you would have your hands up, depending on whatever question you wanted to answer. And this is because concussion is quite a common injury, and it really can cause very significant impact on the child and the family. And so I think we all, by registering for this webinar, I'm feeling your energy that you're interested in this topic. So let's dive right in to talk about what a concussion is. And over the course of the webinar, I'm going to be referring to a few documents that have come out in the last couple of years. This document is from the Summary and Agreement of Statement of the Concussion in Sport group that meet every now and again. They have a big meeting in a European city. The last one was in Berlin in 2016, and they published resources in 2017 and 2018 from that meeting. And this is considered sort of the gold standard in concussion. And so they talk about this being the definition. So concussion is an injury that happens following a direct blow to the head, the face, the neck, or it can be elsewhere in the body. So for example, a body check where that impulsive force is transmitted up to the head. And what happens is there's a sort of rapid onset of changes at the level of brain cells that cause sort of a set of symptoms in the patient. And then over time, these tend to resolve spontaneously. There are certainly some kids and adults who will have prolonged symptoms. You may even know somebody who's had prolonged symptoms, but in general, this is an injury that people will get better over a period of time, and things will resolve. When we use the term functional disturbance, what we're talking about is that there's nothing to see in terms of if we did a special CT scan or an MRI, for example, just standard imaging that we use in the hospital. We don't see a bruise, we don't see a bleed, we don't see a fracture, we don't see anything on that standard neuroimaging. And that's because this is a functional disturbance. It's happening at the level of the brain cells. And this is what, and we'll go into a little bit more detail just so you can understand what that means, but it just means that the scans are normal, and that's why we don't routinely order scans in a concussed patient. And then the last point, this has been out in the literature for the last number of years, but just to sort of put to bed this notion that you have to lose consciousness to have a concussion, you definitely do not need to have a loss of consciousness. And so this can happen even in the patient who does not report that they lost consciousness after their injury. So in medicine, we use this term pathophysiology to try and describe like what is happening with this injury, what's happening to cause the patient's symptoms. And if you use that little cartoon that shows the head moving in that sort of whiplash kind of mechanism, where the head the head and the skull, which are sort of fixed, are accelerating or decelerating, or especially rotating. And you can imagine that the brain is not totally fixed inside the skull, so it can move as well. And so the brain is moving. It has compressive, it has tensile or sort of pulling or shearing forces on the brain, and these cause the changes in the cells that give the patient their symptoms. This is these are a lot of big words that maybe when I give grand rounds a little bit later this morning, I'm going to go into a little bit more detail for the physicians at the hospital. But all these words basically describe that on the level of the cells, under the microscope, lots of stuff is happening inside the brain cells. And what happens is that there's a lot of alterations in terms of how those brain cells are functioning, how they're sending information between the brain cells, and even how there's a change in how the blood flow is going to areas that are injured. And all of this is what causes the patient's symptoms. And so we like to use the term the invisible injury for concussion. You can imagine, I'm sure everybody who's listening today, you've had an injury, you've sprained your ankle, you've cut your hand, and you can go into the doctor and say, look what I did, I hurt myself. And we can see that bruising, we can see maybe the deformity of a fracture, for example. But concussion you can't see from the outside, and we really rely on the patient, the child, to describe what they're feeling and what they're experiencing. And this can mean that sometimes teachers and coaches, parents, even the athlete themselves don't recognize what's happened. And so we have to really have our antenna up for this injury because it isn't so obvious all the time. So I showed you that picture of the brain with the bandage around it, and there's lots of things happening at the level of the brain cells to give the patient their symptoms. But a very simple model for thinking about concussion is just picturing these two girls on the teeter-totter. And so what happens is there's lots of changes in the brain cells, and what the brain would like to do is get back into homeostasis or equilibrium, get back to normal. And to get back to normal, the brain needs energy to get the cells functioning back as they should. Unfortunately, the blood supply to some of those injured areas can be changed or decreased in a concussed patient. And so the energy supply, that ability for the blood to bring, for example, sugar into those brain cells for them to be able to make energy, is decreased. And so we have a situation where we're out of whack. We have a decreased energy supply, and yet the brain really needs more energy in order to heal. And so this is where this concept of rest in concussion comes from, decreasing the demand for energy in the brain, allowing the patient to heal and for the brain to get back into balance. So sometimes if you read about concussion, we use this sort of explanation about it's an energy crisis. So there's a decreased supply, increased demand, and we need to bring things back into balance. Hopefully that explains. Kara's nodding. So we're going to move on. Okay, so as I said, if you guys were in the room with me, I could probably see that a lot of you had your hands up when I was asking questions off the top. And I think we all have a bit of a perception that the incidence of concussion seems to be increasing. Like, gosh, this seems like it's a really common problem. And if you have that impression, it's because it's true. All of the data that we collect around the incidence of this injury would suggest that the incidence is increasing. And there's probably a number of reasons why. The bar chart at the bottom of this graph is from a study that was published in 2016 by my colleague Roger Zemek, who I work with in Ottawa. This is just looking at doctor's office visits and emerge visits in Ontario with a diagnosis of concussion across from 2003 to 2013. And the number of visits is on the y-axis there, the 10,000 and 25,000. So you can see there's lots of visits. And you can see that it's kind of stable. And then we have this nice curve up, 2009, 2010, up to 2013. So really you can see in blue and white there that it's there's this increasing incidence. And people often ask, how is it that this is increasing? And there's probably a few things going on here. The first is increased awareness. And I think, those of us who are older can remember, people would get their bell rung during a game at high school or that sort of thing, and nobody would really think anything about it, and the child would be, or the teen would be back in playing either that day or the next day. Nobody would be too worried about it. So certainly the research has really led to an increased awareness of this being a very significant injury. And so people, in general, the lay public are more aware of concussion. So that probably leads to a little bit more reporting. The second thing is media exposure. And so there's been lots of high profile cases of athletes, for example, with concussion. And that also leads to increased awareness. And what's interesting about this graph from Ontario that I'm showing you here is that between 2010 and 2011, that was when Sidney Crosby had his recurrent concussions that took him out of the game. So the most famous hockey player And certainly the media exposure around his injury probably also helps with this bump. But if you talk to sports medicine doctors, they actually think that there is a true increase in incidence in this injury, probably related to the increased participation in organized sports among children, and as well the fact that young athletes tend to be faster, stronger, and that may lead them to more aggressive styles of play that might put them at risk of injury. So there is probably a true incidence, but there's also an increased awareness amongst the public as well as increased media exposure. And that's probably what's driving this increased incidence. And so when we're thinking about it, like in the States, they report maybe up to 1.9 million concussions per year in kids under 18. Certainly where I work, we see over 70,000 kids a year, and we see about 900 concussions a year. So it's a pretty common injury that I see even in my own work. When we look at the States, football for sure for boys is number one, and soccer for girls is number one in terms of sports-related concussion. In Canada, hockey is obviously a very common driver of this incidence of increased concussion, and soccer in girls for sure. Okay, and there's definitely a higher rate in competition versus practice. Lots of our evidence really comes from the sport-related concussion. So when we're thinking about concussion in youth, almost half of Canadian kids participate in an organized sport at least once a week. And you're 6 times more likely to experience a concussion in an organized sport than doing other types of play. Concussion, as we mentioned, is the most common specific injury in minor hockey. And we all know, probably some people in this audience have somebody in their house who plays hockey. It's such a common sport for us in Canada. And then there's an estimate that there's a 10 to 15% annual concussion rate in youth athletes. So while we want kids to be active, we have to be aware that there is a risk with organized sports in particular in terms of having this injury happen. So all in all, for those of us who work with kids, and I'm presuming everybody on this call does, this is a pediatric problem, and this is why we have to be well aware of it. It's a common injury in kids. Kids take longer to get better. So on average, adults take about 7 to 10 days to get better from their concussion, whereas we know kids, it's about 2 to 4 weeks on average, okay? And we'll talk about the kids that are at risk of having prolonged recovery. And we know that this immature brain seems to be more, just more sensitive to the disruption that we talked about before. And that's probably just because the brain is maturing and there's lots of changes happening at the level of the cells as the child develops. And so this brain is really precious and really needs to be protected. So we'll continue to stress now. I think I've probably made you all worried, but we need just to stress that we need to manage pediatric concussion conservatively, because we need to protect these kids' brains, understanding that if they continue on in sport and activities, that recurrent injuries can cause cumulative effects in the child's brain and may affect their development and how they're doing at school. And so we have to be really, really careful with these kids. So one of the tenets of concussion that has been in the literature for a long time and hasn't changed is when in doubt, sit them out. And this just reminds us that if we're a trainer or helping on the sidelines, or we see a child in gym, or we see a child in our care who we are concerned about having had an injury, then we take them out of play and they never return the same day. Okay, so that has not changed. So when in doubt, sit them out. Okay, so as we're moving through the rest of the webinar, I want you to think about Amy. Okay, so this is our patient that we're going to think about. This is maybe our daughter. This is maybe a kid on our team. So this is a 15-year-old healthy kid. She was playing hockey today. She got boarded, so she got body checked into the boards. She had that movement of her head that we talked about. She did not have a loss of consciousness, so that's what I mean when I say LOC. She is amnestic, so that means she doesn't remember the injury. She remembers skating, and then she remembers coming off the ice, but she doesn't actually remember getting hit. She complains of headache. It's not too bad, but she complains of a headache. She's quite dizzy, and she's vomited once. Her GCS, or Glasgow Coma Scale, is 15 out of 15. So she's alert, she's oriented, she's speaking normally, and she has a normal physical exam when she goes to see the doctor. So we're going to keep in mind this patient, Amy, as we move through the rest of the webinar. So as I mentioned, when we were talking about doing scans for concussion, there's no way to actually do a test, like a blood test or a special scan to make this diagnosis. And that's why it becomes quite difficult sometimes to sort of figure out what's what. But we need to, so we start by taking a good history of the injury and history of the patient's symptoms. And so we can think about the symptoms for concussion in terms of 4 different domains, and they're represented by the colors on this chart from Holland Blue Review in Toronto. And this is looking at physical symptoms, mental symptoms, emotional and behavioral symptoms, and then impact on sleep. And so these are the 4 domains we need to think about when we're seeing a patient with concussion. Physical things like headaches, nausea, dizziness, and being sensitive to light and noise. Mental symptoms that patients often comment about is that they feel kind of slow, they feel foggy, they're having difficulty concentrating or remembering. And then there's often emotional and behavioral changes, especially in young kids, irritable, being nervous or anxious, frustrated, angry, sad. So asking about those questions might not be something that you kind of immediately think of, but we have to think about that, the impact on those behavioral issues. And then sleep is huge. The impact on sleep in concussed patients is quite significant, and so asking about sleep is very important. So either sleeping more or less than usual, or having difficulty falling or staying asleep. So these are the 4 domains that we need to think about when we're thinking about symptoms in concussion. This is a very busy slide, but just to show you that there are many published symptom inventories for concussion, and this would be for a healthcare provider to be able to see how the patient is doing. So going through a big long list, this is the post-concussion symptom inventory, it's called, or the PCSI, and it goes through all those different questions about all the different physical or mood symptoms, for example. And this one is nice in that it asks what the patient, if they ever had any symptoms before the injury, because you can imagine if you have a teenager, for example, they might have times when they feel sad or fatigued or have had headache. So even at baseline, they might have a few of those symptoms. But then you want to ask, how are you today after the injury? And this is a way that the healthcare provider can kind of serially see the patient and see how are we getting back to baseline. We have an idea of what your baseline looks like and how are we doing compared to that after the injury. So this just reminds the healthcare providers who are seeing patients that there's a long list of symptoms and we do need to think about asking about all of them. Headache is the #1 symptom, and that's the #1 source of stress for families. For any of you out there who've had a headache or suffer from migraine, you know this can be pretty debilitating. And so headache is a really common symptom. And then, concentration, fogginess, difficulty thinking, dizziness. Those are probably the most common symptoms that I hear about when I see a patient in the emergency department. In order to make a diagnosis of concussion in children, you only need 1 symptom. So if you have a plausible mechanism of injury, so the patient got hit, head, face, neck, or their body with a force transmitted up to the head, and the patient is symptomatic afterwards, that's enough to make the diagnosis. We don't need a scan, we don't need a blood test, we don't need to do anything fancy. That's all they need. And so we have to be, so that sort of speaks to the being conservative in this age group. Even 1 symptom is enough. After the doctor or the healthcare provider who's seeing the patient takes the history and gets a kind of full idea of what exactly happened and how the patient is feeling now, they need a full physical examination. And that would include examining the head and the neck to make sure that there's no more serious injury that might need a CT scan, for example. And then what we would call a full neurological exam, just making sure, again, there's no signs of a more serious injury. Part of the neurological exam and the concussion assessment should include balance assessment, because having trouble with your balance is a super common symptom in this population. And so this is an old slide, old picture of this guy doing what we call the balance error scoring system. And you can see on the left, he's standing in a double leg stance where his feet close together, his hands on his hips, his eyes closed, and then for 20 seconds he has to hold that position. And whoever's doing the test for him will count how many times he falls out of the position or opens his eyes or takes his hands off his hips. And then on the right-hand side, he's doing a tandem stance where he puts his dominant foot, so the foot that he would kick a soccer ball with, in front, and his feet are very close together. And you guys can try this at home later. It's not actually that easy to do, even if you don't have a concussion. hands on the hips, eyes closed, and hold the position for 20 seconds. And then count how many times the patient has an error. So their eyes open, their hands off the hip, they step out of the position, for example. And this is just one method of testing balance. There are other ones. And I'll show you later that this tandem stance, the picture on the right, has been shown to maybe help to predict patients who will have trouble getting better. All right, so we're thinking about Amy, our poor hockey player who got checked into the boards. She's had a full history taken. She's had a physical examination. As I mentioned, she was complaining of she had vomited once and she's having some headache and dizziness. And so in the emergency department or in the doctor's office, we need to think about symptom management acutely. And this is this cool dude with his sunglasses and his headphones on. These are simple things that you can do because often you're sensitive to light and to sound when you have concussion. So earplugs, noise canceling headphones, sunglasses. We use regular over-the-counter medication for headache. Sometimes the patient has a significant headache that might require some medicine that we use in migraine therapy. We can try that. We use anti-nauseant medicine if they're feeling sick to their stomach. And then we have to really do a lot of counseling with the family and with the child in terms of what they're going to do to help to get better at home. There's not a lot of evidence for different medicines in concussion. In fact, there's very little. And so we tend to, for example, use medicine we use in migraine if there's headache in a concussed patient. We use medicine that we use in stomach flu, for example, for the patients who have significant nausea. But we don't have a lot of evidence to know exactly what's the best in concussion, and that's really where the next wave of concussion studies needs to look at in terms of what's the best way to treat these patients. And so just to review symptomatic management, we need to talk about sleep hygiene because I told you that that's one of the 4 domains that's really affected in concussion. So really being careful about not having this kid sleeping all day at home and then up all night. Managing the fatigue that's very common with concussion, so planning activities and pacing activities, and then just regular healthy stuff like hydration and nutrition. So that's sort of how we treat things acutely. And then we need to talk to them about when they're going to return to play. So this is the most common question we'll get from parents. When can my kid get back at whatever their sport is? When can they be more active? And this is because people know that historically what we've done is we've told the patient to go home to the bedroom jail. And this is, historically it was go home, lie in a dark room, and when you're better, you can start back at your activities. And we know now, actually, just in the last few years, there's been new evidence that's come out that suggests that actually doing long rest for concussed patients actually leads to longer symptoms. And so there has been a real shift in the last couple of years in terms of what return to play or return to activity looks like in this population. And if you think about it, it kind of makes sense. If any of you've known somebody who's had a stroke, which is a very significant brain injury, we know that those patients are up doing their rehab as soon as they're able. And there are physiological and psychological and functional benefits associated with that kind of rehab for a stroke patient. And so when we think about it, it is a little bit strange that concussion has always been treated a little bit differently. And remember, I showed you the teeter-totter, and rest was, thought to sort of decrease the energy demand for the brain so we can get back into balance. And certainly rest is still important. The issue is around prolonged rest and how that can actually lead the patient to have prolonged symptoms. Yeah, so maybe we'll pause here and take a couple of questions.
So the first question is, what are the nutrition recommendations that you make for concussion management?
Yeah, I think that there's no specific nutrition recommendations, again, an area of research that really we don't have evidence for, but it would be just normal, healthy diet, normal, healthy hydration, Canada Food Guide type of recommendation. So nothing in particular in terms of supplementation, but just regular healthy diet. Yeah, good question.
And then the second one is, how long from the time of injury till the onset of symptoms? I was told that children show symptoms sooner than adults, hours versus a couple of days.
Yeah, I don't think that there is any evidence that children show symptoms sooner than adults. I have never read that. It's very variable. So most people are symptomatic sort of right from the beginning, but there is definitely recommendations within the guidelines that we observe these patients, and that some patients over minutes to hours post-injury will develop new symptoms. And so observation or attention to symptoms over the first day or so is very important post-injury. So that's a great question, but I don't know that there's really a difference between adults and children in that domain. Great questions. Thanks very much. So we've talked about this historical bedroom jail we used to put patients into. Then we talked about there's some evolution in the research showing that, gosh, maybe it's not so good to have a kid in their room for 3 weeks. And so now we're moving in the last couple of years towards this notion that actually exercise is medicine for these patients. And so this comes from, there's a couple of small studies, but there's one big study from 2016 by Gruel that looked at, it's part of a bigger concussion study that we'll talk about in a little bit more detail later, that had over 3,000 kids from 9 emergency departments across Canada. And they were all diagnosed with concussion. They were followed along to see which kids had prolonged symptoms at 4 weeks. They also asked the families to be honest about, had the child done exercise in the first week? So it wouldn't have been what they were recommended to do, but did they? And 70% of the kids had done exercise, even back to their full sport, within the first week. So that tells us that patients don't always do what we tell them to do. So that's, we probably already knew that, but it's, so 70% of the kids were not following what they were told. But amongst those 70% that went back to their exercise within the first week of injury, they had less prolonged symptoms at a month. So 29% in that group had prolonged symptoms at a month versus 40% in the patients that did strict rest in the first week. So that was the first big study that suggests, gee whiz, this recommendation to like go and lie down in a cupboard is really not helpful for these kids. And we still don't know exactly the right timing or exactly how that return to play should happen, but there's been a real shift from having to be completely no symptoms prior to return to activity versus being able to go back a little bit earlier. And so that's why if you're reading new guidelines and you've been interested in concussion for a while, you can see that there's a real shift in terms of the guidelines, and we'll go through that in a wee bit more detail. So this is from that gold standard concussion consensus statement that was, the meeting was in Berlin in 2016, and then they had publications in 2017 and 2018. And this is an infographic from that document. And so it just reminds us that every single person who has a concussion, we're talking about kids today, they need a medical assessment, right? They're not going to be returned to play on the same day, and they need a medical assessment. What we generally recommend now is that there's a rest period. So rest is still important for a day or two until the patient's feeling better. And then they can start what we call now symptom-limited activity. So they're allowed to do activity as long as their symptoms are tolerable, as long as they can manage their symptoms. So it's okay to have a mild headache. It's okay to have a bit of dizziness. As long as you can tolerate the symptoms, you're allowed to do some activity. You can see that there's no resistance training, so no weightlifting, for example, and no contact activity, because we certainly don't want the patient to be at risk of getting re-injured while they're still symptomatic, but they can start to do some activity. So that's a real shift in the last couple of years. If we move on to stage 4, they can start a little bit more light exercise, and they can progress through these steps every 24 hours as long as the symptoms are tolerated. Again, you can see no resistance training, no contact activity. 24 hours later, if the patient was feeling still able to manage their symptoms, they're allowed to start some sport-specific exercise. So that would be skating and hockey, for example. No resistance training, no contact activity. We don't want them to get re-injured, but we do want them to start doing some aerobic activity. 24 hours later, they can start non-contact training. So a little bit of weightlifting or resistance training is now okay, but we still don't want them having any contact activity while they still have symptoms. And then we would move on to step 7 would be medical clearance. So this is when you need to see your doctor. You would need to get cleared in order to go back to full contact practice. And in general, this would only occur if the patient is truly asymptomatic, so no symptoms. Then we're back to full contact practice where contact activity is okay. So this patient is now a little bit at risk of getting re-injured, and that's why we want them symptom-free, and then fully back to sport. So back, normal gameplay, and they've done their full rehab. And so you can see that this stepwise every 24 hours is the way to rehab the patient. And in general now, as long as the symptoms are tolerated, they are able to progress through the steps. If the symptoms become worse or they develop new symptoms, they're instructed to drop to the previous level for 24 hours and then try again. So bottom line for return to play, it's changed a little bit. So now we rest for 24 to 48 hours, we are allowed symptom-limited activity, and we do that stepwise return to play. And so I would encourage you to take a look at the Canadian Guideline on Concussion in Sport. It's on the Parachute website. It's a nice document from 2017. They have good patient handouts, return to sport strategy, for example, and that walks the patient and family through how they return to play. I wanted to tell you about the PEDCARE study, which is a study that we're running in Ontario at 3 pediatric emergency departments. It's just finishing its recruitment now. And basically, this is a study that's looking at 350 kids between the ages of 10 and 18 who are having a concussion, and splitting them into 2 groups. So the first group is patients are resting until they don't have symptoms and then progressing through the steps. So sort of the old way we used to do things. And the other group is resting for 3 days and then very, in a standardized fashion, they're moving through increasing their aerobic activity every 24 hours as tolerated. And basically, the lead authors of this are thinking that this very standardized approach to returning the child to aerobic activity, not allowing them to get injured, so they're not having any contact activity, but progressing them through after 3 days of rest, will lead to improvement in recovery at 2 weeks. And so stay tuned. This, I think, will probably be published this year in 2019 because the recruitment, as I said, of the patients is finished now. And so this will be the first time that they've ever compared 2 groups and followed them along to see what's the best way to get kids back to play. So stay tuned for PEDCARE. The probably more important than returning to activity, even though that's the most common question that we get about concussion, is returning to school. School is work for kids, and for them to be out of school is a big, big problem. So we also do what we would call a gradual return to learn as well. And we really need to make sure that while the patient can do some of that physical activity, they shouldn't be fully back to their sport until they're fully back to school with no supports. So they're back to school doing homework, tests, totally normally at school prior to going back to their sport. And that's a very important message to get through to particularly teenagers around this issue. And so that consensus statement that I showed you the infographic from also has nice tables that go over a return to school strategy. This is just sort of gives an idea about initially the patients at home and resting and allowed to do some simple symptom limited activity. Okay, they can test themselves to see how their brain is feeling in terms of cognitive work by gradually doing sort of 5 to 15 minutes of a time of cognitive work. Then they can essentially we're trying to get them back to typical activities at home. Then they can start to do a little bit more school activity at home in terms of homework or reading. And if they're able to tolerate that cognitive work, they call it, then back to school part-time with a gradual introduction of homework, for example, and testing. And that gradually increases until they're fully back at school. And so this just gives a bit of an idea about what a return to school strategy looks like for patients. This is another document that's available online, the Acute Concussion Evaluation, Return to School. And I sometimes give this to parents because I think it gives a wee bit more information about what going back to school actually looks like and what, how much am I supposed to send them for? What does a half day look like? When do I introduce tests and homework? So we won't go through this in a lot of detail, but this gives a wee bit more detail. And this is an American document from 2014, so I think it still applies. And then this is from Parachute. So this is again from that Canadian Concussion Guidelines that's available online at the Parachute website. Again, going through very sort of in a greater detail in terms of what does return to school look like. And so I think this is a really nice Canadian resource for kids and getting back to learn. Another good resource that's available online is from Dr. Mike Evans, who does whiteboard videos on lots of different topics. And he's got 2 on concussions. There's one about return to learn, and then there's one about just concussion in general. These were produced prior to the new guidelines coming out, but the return to learn one is still quite good in terms of explaining what the symptoms are and what getting back to school kind of looks like. So that's a nice resource as well for parents. Okay, so we'll move on to, just wanted to talk about in a bit more detail about that big study that I referred to. This is the 5P study, and the reason why it's called the 5P study is because it's impossible to say the title, but I'm going to say it right now. It's the Predicting Persistent Post-Concussive Problems in Pediatrics study, or 5P for short. This was published in the Journal of the American Medical Association in 2016, a very big um, uh, study, the biggest study in pediatric concussion ever. So really an important document in the research associated with concussion. And this was, again, just to remind you, it was looking at over 3,000 kids, Canadian kids, seen at pediatric emergency departments across the country. And they were followed along for a month, and even longer in some cases. And basically, what the authors wanted to find was how many kids still have symptoms at 28 days. So, how many kids are still symptomatic at a month? And what they found was it was 30% of kids were symptomatic at a month. So, almost a third of kids, we said off the top that kids usually take 2 to 4 weeks to get better, but a third of kids will be still symptomatic at a month. And so, that's very important when we think about how we counsel families. And even for ourselves, if we have somebody who has a concussion in our house, a third of the time, the symptoms can really last. And I wanted to show you a few little graphs, and we're just going to take a little time because part of the study was looking at quality of life. Okay, so I'm just going to take a little bit of time to explain this graph to you. On this y-axis, it's the score on a quality of life questionnaire that's used in kids. Okay, the higher the score, the better the quality of life. On this axis, hopefully you can see my arrow, it's the time from injury, 4 weeks, 8 weeks, 12 weeks after their injury was diagnosed. The blue dotted line is where healthy, normal kids usually score, okay? The green line are the kids who are better from their concussion and don't have symptoms anymore. And the yellow line are the kids who are still having symptoms after 4 weeks. So you can see that overall quality of life, so this graph is for overall quality of life. The kids who are better from the concussion are almost back to the normals, but the kids who are still having symptoms, it's not surprising that their quality of life is quite a bit less. Okay, so this is just kind of getting just a visual for the impact on daily life in kids. And this study was looking at 5 to 18-year-olds. Okay, so a nice cross-section of children. There are some subscores looking at physical functioning and emotional functioning. And you can see that the kids who are better from their concussion, the green line, they're essentially the same as the normal kids who take this questionnaire. But the kids who are still having symptoms, the yellow line, they're quite a bit below, significantly below in terms of their physical functioning and in terms of their emotional functioning. So lots of different domains of their life are affected with this injury. And then we look at social functioning. Again, the kids that are better from the concussion are essentially the same as the normals, or maybe even a bit better, interestingly. And the kids who are still suffering from symptoms are below. But the school functioning graph, I think, is very interesting. It shows that the kids that are better from the concussion are still quite a bit below in terms of their school functioning compared to the normals. And the kids who are still symptomatic, no surprise, they're way down. And so this just reminds us, especially those of us who are in education, that even kids who are not saying that they have still symptoms of their concussion, they may still need some support for school. School is still, even up to 12 weeks out from their injury, they're still having difficulty at school. So kind of sobering, actually, this part of the study looking at quality of life in kids who've had concussion. One interesting study that just got published this year looked at toddlers, preschoolers, in terms of what are they like when they have a concussion. And we have hardly any evidence in this age group. As you can imagine, I've told you off the top that there's no blood test or special scan to make this diagnosis. And so we rely on a patient report of their symptoms. And of course, when you're 3 years old, you may not actually have the verbal skills to be able to say, Mom, I have a headache. And so we sort of have to just look at behavioral change to sort of make the diagnosis of a concussion in young kids. And so this study looked at 229 little kids. On the average, they were 36 months, so they were 3 years old. And one part of the group had a head injury that was felt to be concussion. One part of the group had like a fracture, so they had an orthopedic injury. And then one part of the group were normal, healthy, developmentally normal preschoolers. And basically what the authors did was they just asked the mums at 6 months to talk about their child's behavior. So they filled out a special questionnaire regarding behavior. And they found in the brain injured group, so the concussed group, that there was a significant increase in, they talked about two different types of behaviors, internalizing and externalizing behaviors. So internalizing in terms of mood or anxiety being lower, and externalizing behavior would be like difficulties with attention and behavior and conduct. And so it just reminds us that even in these young kids, so we've just talked about quality of life in the older kids being impacted by the concussion, in little kids who we don't have hardly any evidence about, even 6 months out from the injury, there's an impact on behavior with what's considered to be a mild brain injury. And so again, just reminding us that we have to really respect concussion in terms of its impact on life for both the patient and the family. Okay, so we're back talking about Amy. You guys remember Amy? She didn't have a loss of consciousness. She didn't remember getting hit. She's complaining of a headache, but it's not too bad. She's pretty dizzy. She's vomited once, but the rest of her examination is normal. So why did I pick a girl? The reason I picked a girl is because girls are at risk for this injury more than boys. So concussion is a bit more common in, overall it's going to be more common in boys because they're the injury group that is always higher. In any injury literature, the boys are always higher. But girls are more at risk, and they're more at risk of having persistent symptoms. And the reason for that is not really well understood, but there's some theories, sort of three main theories about why girls are a bit more at risk. The first is that their necks are a little bit less strong. So the neck musculature is a little bit less strong, and so they're a bit more prone to that whiplash type injury. The second is that there's some hormonal reason why they're more sensitive, so estrogen, for example. And then the third is that maybe girls are just more honest about reporting their symptoms. And so we don't really understand why, but there is definitely an increased risk among girls. But I talked to you about that study, that 3,000 plus kids followed for at least a month after their concussion, and 30%, you'll recall, were still symptomatic at a month. And then what the authors wanted to do was to say, is there a way that we can predict who has trouble? And they did some fancy statistics, and they came out with this list of 9 features that are associated with having prolonged symptoms. So this is the 5P study that was published in JAMA. This is a scale that's out of 12. The higher the number on the scale, the higher the risk of having prolonged symptoms at a month. And so if we were going to score our friend Amy, she gets 2 for being a teenager because they're at higher risk of having prolonged symptoms compared to younger kids. She gets 2 for being a girl. We already talked about that. The third question is asking, if you've had a concussion before, did it take you longer than a week to get better? She's never had a concussion before, so we're going to give her a 0 for that. She does not have a personal history of migraine. She was not answering questions slowly in the emergency department. She was quite good when she was being assessed. But when I got her up to do that test, remember that test where you have to put your foot in front of the other one and put your hands on your hips and have your eyes closed? That's called the tandem stance. She's quite dizzy, so she had a lot of trouble. She had more than 4 errors. She fell out of that position more than 4 times when I asked her to do it, so she gets a 1 for that. She's had headaches, so we give her a 1 for that. And she's feeling very tired, so she gets a 2. So her total is 8. And what the authors looked at was, gee, let's see with their statistics, if your point total goes from 0 to 12, this is your percentage of risk of having prolonged symptoms at 1 month. Okay, so you can see if you have 0 on that score, you have a 0% chance of being still symptomatic at a month. But if you have 12, you have a 100% chance, and it's almost in a straight line going up. And so this is the rule that they came up with, the 5P rule, looking at can we better predict who's going to have a longer time to get better? And these are what the factors that they identified were. The authors have a website called 5P Concussion that they developed. It has the score, so you don't need to remember that you can score the patient, and then you press enter, and it brings you to the score calculator. And what it shows for our friend Amy, she's an 8. So she's got a moderate or medium risk of having symptoms. So somewhere around sort of 30 to 50% risk of having symptoms at a month. And so this can help to, when you're seeing the patient, for example, when I'm seeing a patient in the emergency department, to actually be able to counsel the family. Yeah, most kids are better between 2 and 4 weeks, but there are some kids who seem to be at higher risk. Your child is sort of falling into maybe that higher risk category. So let's just have our radar up for that and ensure the patient has really, really good follow-up. And so all of the guidelines would say that at 4 weeks, if the patient is still having significant symptoms, so that's usually sort of 3 or more symptoms compared to what they're like at baseline, that they need referral to specialized care. And that really depends. What that looks like depends on where you live. That could still be working with your family physician if there's not a lot of resources in your community. That could be seeing a sports medicine physician. Or in some of the bigger cities, there are what we call multidisciplinary concussion clinics, where you'd have psychology, physio, occupational therapy, sports medicine, all working together to help with the patient's rehabilitation. But the guidelines would all state that at 4 weeks, the patient does need specialized referral if they're still symptomatic, because they're falling now into that group that's a bit at higher risk. The Canadian Pediatric Society published concussion guidelines in 2014, so they're not totally up to date in terms of return to play. But they do have a nice table. Table 5 in that document talks about what kinds of things we do for patients who have persistent symptoms, talking about managing headache. As we mentioned, that's the most common symptom. We got to make sure that they're essentially, their sleep is okay, that they're not using too much over-the-counter medication, because that can actually lead to headache on its own. Sometimes we use preventing medication that we use for migraine in this patient population if they have really bad headaches. And often those kids may need to be seen by neurology for help with headache management. If they've got neck pain, physio is very helpful. If they've got ongoing dizziness, we do something called vestibular rehabilitation, just to get them more tolerant of head movement and that sort of thing, so they don't get too dizzy. Sleep disturbance is a key thing to ask about and to manage. So sleep hygiene and using medications, for example, like melatonin. And then there can be very significant mental health impacts. You can imagine just the injury itself can cause some issues around depression and anxiety, but also the removal from your social circumstances. Maybe you're not totally back at school, you're not able to play your sport. All these things can really lead to mental health concerns in the patient. And so these patients often need referral for a supportive counseling or cognitive behavioral therapy, for example. So, I'm sitting in the Prevention Institute, and so we're going to talk about prevention. So education around this injury has been really, really important in terms of increasing awareness. We talked about that already, and decreasing the use of CT scans when you don't need them. But the most important thing that has caused a change in concussion incidence has been rule changes. And the greatest example of this is in minor hockey. So we had a ban on body checking until ages 13 to 14 in Canada, starting in 2013. And there's a really nice study from Black in 2017 that looked at kids aged 11 to 12 playing minor hockey before the ban and after. And so before the ban, those kids would have been body checking. And comparing the two groups before the ban and after the ban, there was a 64% reduction in concussion in that age group. So clearly, rule changes are the way to go. Okay, that's nothing else is going to have that impact. So I would say rule changes super important. And then from a coaching perspective, making sure that kids are playing according to the rules, not encouraging an aggressive style of play, and ensuring that refereeing, for example, is adhering to the rules, and that coaches in their practices are not encouraging kids to have unnecessary contact within practices, for example. So there's a lot of things that can happen sort of at the level of organized sport to try and decrease these injuries. The other piece, we talked about girls being a bit more at risk, and maybe it's because their neck is a wee bit weaker. And there are some studies that suggest that with actually just conditioning neck strengthening could be an intervention that actually decreases the rate of concussion. So that is something to think about in for example, in organized sport for the conditioning of athletes. So then there's things that people always ask us about. Helmets. Helmets are absolutely vital in protecting children and adults against severe brain injury and significant brain injury like fractures, bleeds, things that need to go to the operating room, okay, has absolutely changed the landscape of serious brain injury. But there is no helmet on the market at present that prevents concussion. And so there's a lot of companies that will tell you something different. But as you can imagine, if that brain is moving within that hard skull, within that helmet, it's hard to imagine that a helmet's going to be able to prevent that injury. It can withstand some forces. It is key for protecting against serious brain injury, like we've talked about. But we need to be careful about falling into the trap of these marketing schemes that tell us that helmets are going to protect against concussion, because there's really no evidence to support that. Mouth guards, there's a bit of mixed results on mouth guards. Again, mouth guards are very important at preventing dental and jaw injuries, or maxillofacial injuries. That would be the term that we would use. But there's mixed information about whether it really helps to prevent against concussion. There's one what we would call a meta-analysis, looking at a number of different studies that suggest there may be a trend to helping to prevent against concussion. So by no means am I saying not to use helmets and mouth guards, absolutely, but we need to just be cautious that they are not, we're not having a false sense of reassurance that this is really going to have a big impact on preventing this injury. Really, rule changes like we've talked about before is going to be much, much more important, okay? Certainly very important to wear the protective equipment, but just be aware that, especially when you're getting marketed to by these companies, that there's really no evidence at present. The last two things on this list, pharmacotherapy or medications or nutritional supplements, for example, there's absolutely no evidence at present to suggest any particular product in terms of preventing or decreasing the incidence of concussion. So again, let's not fall into the trap of marketing strategies from some of these companies. I wanted to let you know about a really good resource that was first published in 2014 and is currently being updated and will probably come out in June 2019. So I saw a draft just last week, and it's pretty close. And this is a really comprehensive document. So it's going to be the latest and greatest this year. It's available at the Ontario Neurotrauma Foundation website, or onf.org. And this is a really nice document in that it's absolutely totally comprehensive, A to Z. But there's one available for doctors and healthcare providers, there's one available for coaches and trainers, and then there's one available for parents and families and athletes and children. So there's sort of three versions, and within the document, all the handouts and the extra documents that you require are hyperlinked within the document, so it's really comprehensive. There's management of sleep hygiene, headache, when you need a CT scan, how to return to play, how to return to learn, all of those documents. Even letters for school, accommodations at school, it's all within the document. So depending on what your background is and how you come in contact with kids with concussion, this is a really good resource. And as I mentioned, it's going to be updated and out in the summertime. Another nice resource is from BC, this concussion awareness training tool, which I did it a few weeks ago just to see what it's like. And it's actually very good. Again, you can see there on the homepage that you can select based on what your background is. And it's really a nice, comprehensive, up-to-date training tool. It takes a couple of hours to do. It's interactive. There's questions that you answer throughout the little modules. And so I think a really nice resource, again, a nice Canadian resource. And I think that's all I have for you today. So I can see that there's lots of questions. So maybe we'll go through those now.
Okay, so we talked about that one. Okay. What's the current recommendation on taking anti-inflammatories in the acute phase?
Yeah, I think so. That's a great question, Michelle. There's you'll see, a little bit of, sometimes there's a little bit of a debate about whether you want to use something like Advil if you're concerned for a bleed. Of course, this patient, once you have done a full assessment and ensured that they do not need further, like a CT scan, for example, and you're not worried about a more serious injury, you can certainly use either acetaminophen or ibuprofen in this population. Clearly, if you were worried that there was something more serious going on, you might not want to use that anti-inflammatory like ibuprofen because it affects platelet function. And so, but once we've ruled out those things by our very thorough assessment, we can move on and use the over-the-counter medications. When I talk about medication overuse, if you're using a lot of Advil and Tylenol, more than, and I just use the brand names there just for ease, if you're using regular Advil and Tylenol more than sort of 2 to 3 times a week, that can actually lead to a medication overuse headache. And so that's the caution. We just need to be a little bit careful with patients who are, so in the acute phase, you may use it a bit more regularly, but if you have ongoing overuse of those meds, they can cause their own issues around a medication overuse headache.
then Catherine asks, did I hear correctly? Following an injury, there's less blood flow in the brain.
Yeah, I mean, there's what we would suggest, what is sort of suggested by the research is that there's altered blood flow. So, I probably would use that term. And certainly, probably in some areas, it is decreased. And so that's where you get that decreased energy supply. But when you read about concussion, they often use the term altered. And that's probably based on studies using very fancy kind of scanning, like PET scanning, for example, or functional MRI, that actually shows that there may be sort of decreased blood flow to certain areas that are injured. Yeah.
And then the next one, if the concussion goes unnoticed, what are some of the things or issues that can happen in children?
Yeah, I mean, I think that if the patient is symptomatic and doesn't report, for example, don't do that period of rest at the beginning and then sort of a gradual return to play, a couple things can happen. There is a risk that the symptoms may be prolonged because they haven't sort of done their rehab appropriately. There's a chance that the patient goes back to play and actually gets re-injured. And we know that the effects can be cumulative. So we certainly in my practice, I see kids who've had more than one concussion, and it often takes them longer to get better. It often really affects their academic performance. And there can be significant mental health issues as well, chronic symptoms like headache and that sort of thing. You will hear about something called second impact syndrome. That's a very rare condition that is only reported in teenagers and young adults. There's only a very small number of case reports in the entire world, and it's felt to be related to a patient who has an alteration in their blood flow. Things are the regulation of blood flow, et cetera, in the brain is altered after concussion. They go back to play while they're still symptomatic, and they have another significant injury. These are patients who die on the field. This is not a mild injury. This is not another concussion. This is a patient who has very profound brain swelling and dies without absolutely emergent medical intervention. And so super, super rare, but something we always have in the back of our mind. I think when we're counseling teenagers, it's such a rare event that they can't really get their head around that might be something they need to worry about. It's more important to talk about delaying their return to their sport, delaying their full return to school, putting them at risk of having prolonged symptoms. And even sometimes it can lead to having to be retired from their sport. So those are sort of the more helpful counseling things that I do for kids in order to encourage them to report when they have the injury so that we can do the right steps.
So Aileen was asking about the steps 1 to 7 in that blue document. Are they 24 hours?
Yeah, they are 24 hours apart as long as the patient's symptoms are tolerable. If they become more symptomatic or they're having more difficulty, they drop to the previous step for another 24 hours and then start again.
And then how do you monitor what the athlete feels is tolerable symptoms? They may not understand that definition.
Yeah, I mean, exactly. I think, Joan, you raise a good point. This is all based on personal report. And so it can be quite challenging to actually get at that. I think it means that, that they feel that they need to stop, that they feel that the symptom is worsening. If the symptom is mild and it doesn't impact their ability to do the step, then that is how I would describe it to the patient. But it does really come down to how they understand it, and it can be challenging. But I think getting at the idea that if the symptom is worse enough that they feel that they need to stop doing, let's say the jog that they're doing, if the dizziness worsens to the point where they need to sit down, for example, or they feel nauseous, then that really speaks to the fact that it's actually not tolerable. So I probably would try and give them some examples.
And the next one is, so complete return to school should not overlap with return to activity?
So return to activity, they're happening together. And so in that parachute document that gives the instructions about return to school, they can be happening at the same time. However, the full return to the contact practice, which is right at the end, I believe it's step 8, that really should not occur until the patient is fully back at school, without any accommodations at school, so full homework and testing and that sort of thing. So that would be the only caveat that I would say to that, is that they're happening simultaneously, but the full return to the sport where they're at risk of having contact activity and perhaps repeated injury should really not happen until, like, that full medical clearance should really not happen until the patient's fully back at school.
Okay, and are there studies regarding persistent symptoms for longer than 1 month?
Yeah, I mean, there are some for sure. That is a group that we don't have a lot of evidence on. That the 5P study did follow. You can see from the quality of life data, they did follow the kids even out past 12 weeks. And so that's probably the biggest study that looked at how those kids are still having difficulty out past past 3 months. So there's some data. There's not a lot, but the 5P study is the biggest cohort to date, followed out beyond 4 weeks.
And then melatonin can be used with the pediatric population?
Yeah, melatonin is used for sleep in peds. It's, it's not like there's a lot of studies, so it's like a lot of medications in peds where we use it a little bit off label. But certainly that's probably one of the most common medications that's used, or supplement, I guess, that's used for sleep disturbance in peds, and often a first step in a patient who has some sleep disturbance. Yeah.
And then just really quickly, last one, are there studies looking at school accommodations and length of recovery?
Lack of accommodation. Yeah, I no, I don't think that there are any studies, but I think you raise a good point that that if the school isn't on board, it can really impact the patient's recovery. And so one of the things that they are going to need to do in terms of accommodation are things like, allowing the child to do part-time with no homework, maybe having a student tutor or other supports in the classroom, like for note-taking, allowing the child to take breaks, allowing the child to eat lunch in a quiet area, for example, not having to go into the gym or into the shop class or into the cafeteria. So because of the sensitivity to noise. And even the simple thing where the school says, we are going to support you during your recovery, so that it takes away the worry of the child that they're not able to complete their homework and testing. That can be very powerful. Ensuring that there's only one exam on a day, for example, in high school, where they might have multiple exams on a single day. So there's lots of things the schools can do, and we really need to advocate for concussion patients within the school board. And that's why in those guidelines that are from Ontario, there are lots of school-related resources in order to really standardize what the school needs to be doing on their end to support the child as they recover.
Well, thank you very much for this webinar today. We really appreciate it. And yes, I will send out the link to the recorded webinar for everyone who's been asking. Thank you very much for joining in on the webinar today, and have a great day.